welcome everyone. Today is September 15th, and it's our September Study Club. And today our guest speaker, or commenter, kind of discussion, question and answer person is Dr. Daryl Yorick, and I have worked with him for a few years. But I did a little Googling on you, Dr. Yorick, so I could have something official to introduce you with, and
okay.
I found out he is originally from Texas, and he earned his dental degree and orthodontic degree from the University of Texas, and he started practicing orthodontics in Washington in 1995 when you guys moved to Tacoma, and you've been in dentistry for about 35 years, according to LinkedIn. So I know that Dr. Yorick enjoys speaking and lecturing because I've actually given a presentation with him before to one of our referral partners in West Seattle. And I think I was speaking about tongue tie, if I remember correctly, and you were talking about the airway, and I think we made a really good team. So a little bit of a backstory on Dr. Yorick is that he's the first orthodontist I met in Seattle who knew what myofunctional therapy was. So I was really excited when I met him. He even told me that he was doing a few exercises with his patients in his orthodontic practice, and I thought, oh my gosh, that's so cool, we need to work together. And so since then, we've kind of, gone back and forth with referring patients and talking about the airway and things like that. Dr. Yorick is also the first orthodontist who ever sat down with me and showed me the airway on an x-ray and pointed out enlarged tonsils and adenoids, and I thought that was pretty awesome. So, Dr. Yorick, anything else you want to add to that?
I guess background-wise, I was blessed to go to a school at the University of Texas at Houston that allowed a very progressive, broad-spectrum sort of approach to orthodontics, including a lot of orthopedics. And so we actually had a European among our classmates who was exchange student. So he opened a lot of our eyes to the European way of looking at things, which has always been more growth and development oriented. And so luckily I got started on an early path toward looking at things like form versus function, asking questions about why an upper arch is constricted, for example, and looking outside the box of just the teeth. And so I was blessed to be able to from the very beginning kind of question I wouldn't say question, but have more in mind than just producing a set of finished models that fitted together a certain way at the end of treatment. I was started looking at the face and then therefore kind of the function of the whole airway and face early on. So I kind of it seems like my life's been blessed in so many ways. But I bumped into people from Europe. There was a Dr. Henri Petit from France that was talking about large tongues and airways and open bites and developing the airway literally back in the late 70s, believe it or not.
Wow.
When I first got started on this, and he happened to be working or visiting professor at Baylor University in Dallas for a few years, and I heard about him and went and took his course, and just kind of changed my life. Just things like that happen to me over and over again. So I don't think it's any accident that I was led down this path. It was very much by some sort of strange design, but I feel very blessed and gifted to be able to be in this position.
That's perfect. It goes right along. My first question was going to be actually asking you, I know that to a lot of doctors and dentists, looking at the airway is kind of an outside-of-the-box thing. So my first question was, is this something you've always done for your patients, or what led you to it? And it sounds like your school and then kind of the people that you met along the way led you down that path.
A great example, was Dr. Henri Petit, because he was lecturing on difficult cases, which in those days he was focusing on open bites and then underbites, the prognathic route. Because, the maxilla, being part of the skull family of bones, is not designed to grow a lot, or it's not an easy bone to move around. So if you had a child that had, or a patient that has an underbite, and due to a deficiency in the maxilla, which it usually is, you're really limited to what you can do. So he got everyone's attention talking about how to treat underbite cases, and almost invariably there's a large tongue involved, and there's a downward and backwards position of the tongue, and so his lecture just kind of merged nicely into and really a very early lecture on the airway and how to approach it. And he was doing things like doing the palatal expansion. They still are doing a lot of tongue reductions in Europe because the tongue sometimes is oversized. And he also led me to develop he had developed some exercises to force a child to breathe through their nose because, just the force of the air moving past the adenoids will cause them to shrink. And he was talking about this 40 years ago. So, and still, it's still kind of considered to be kind of a new thing now. So that was a wonderful experience for me to learn, from a master like that while he was still with us.
That's amazing. So when you're looking at the airway in your patients, what's the main thing that catches your attention? Is it the tonsils? Is it a narrow palate, the tongue? Like, what do you normally pick up on first? And what would you kind of recommend that hygienists who are, actually everyone here is a hygienist and everybody has some involvement in myofunctional therapy. They either practice or they're learning about it or they're experienced. And so what would you say is a good indicator that somebody has a compromised airway?
Well, I think the first obvious thing just from initial impression is, open mouth posture. The classic open mouth posture where the kids have difficulty sealing their lips and they're more comfortable with the lips apart. That's, telltale sign. Then you notice the dryness of the lips because, with the lips apart, they're going to be, they're probably going to have dry lips. And they are invariably the gingiva above the upper incisors has got that red border on it because, the body doesn't like having dried out gums, so the gingival health of the upper incisors particularly, reddened, and so those are the classic signs.
The open mouth you can see before you even look inside the mouth. You can see that in a patient without even having to look at their teeth, right?
Yeah, I asked the parent. I just asked the first leading question I have is, would you say that does she normally have her lips? If a patient's a girl, does she normally have her lips apart like that most of the time? And they'll say, yeah. So, well, how about at night? You think when she's sleeping, is she breathing through her mouth or her lips apart? And I go, yeah, she's a mouth breather at night, or yeah, she's a mouth breather day and night. Well, then they're making your diagnosis for you right there.
Mhm. Yeah, I think that's a good thing. All of us myofunctional therapists can recognize an open mouth, and if that's an indicator that there's stuff going on with the airway, those are all the patients we're seeing. So that's why I think it's so important for all of us to be aware of these things, and for the most part we are, but I think it really helps all of us as myofunctional therapists to hear doctors who totally get all this, because we're kind of used to the opposite, where we go talk to doctors and they're kind of like, well, what do you mean she needs myofunctional therapy? So do you have any advice that might help us myofunctional therapists kind of connect with doctors who might not understand the airway? Or, how do you think might be a good way for us to talk to orthodontists who don't know what you know?
Boy, that's a great question.
It's a hard one.
I have the same thing going on when I run into an ENT doctor or a pediatrician doctor that doesn't really, put much value on an open airway. So it's so with the medical doctors, I usually write a letter, and usually I have a lateral X-ray head film. We call them a lateral cephalogram that shows the constricted airway and large adenoids, and that helps me a lot. You guys you may or may not have that in your practice, particularly if it's a non-orthodontic practice where you don't take a lot of lateral profile X-rays. So let me think about that for a second. To get an orthodontist, well, I would say I would approach it really from the open bite category, because orthodontists hate open bites, and we have a hard time dealing with them. So you might open the floor up like, well, tell me how you treat open bites and what's your success rate, and if they mention the word tongue, then oh boy, there's your opening,
That's
so a good way. So you could. Another way to just to kind of broaden that conversation, actually to deepen it, would be, well, in open bite cases, do you use things like the little tongue spines or tongue cages or anything like that? Yeah, rakes or cages, and then if they say yes, then you can say, well, why? Do you feel like there's a role of the tongue in this open bite? Of course, they have to say yes, right? And then you can go, well, there's another way to deal with this that's more permanent and actually more beneficial for your patient. And let's get the tongue into a normal posture because, by the way, in case you don't know this, it's really the passive resting posture of the tongue that shapes the arches so weird and opens up the bite. We focus a lot on the tongue in motion. The tongue thrust is what everyone talks about. But the resting posture of the tongue is what does a lot of the damage, especially at night. And, of course, that will open his eyes up to think, oh, wait a minute, if I don't alter the resting posture of this child's tongue, I'm going to have relapse here. And, orthodontists, we hate relapse as much as we open bites. Of course, relapse and open bite, it's hard to say one without saying the other because
exactly right.
They walk through this world together. You might say.
Well, it's funny because I was just at that AAMS conference that I told you about, and one of the doctors there said, you guys shouldn't be called myofunctional therapists. You guys should be called myopostural therapists. And I thought, oh, my gosh, that's so true because, yes, we are dealing with the function, but the posture is really what is causing a lot of the developmental issues with the teeth and the jaws and all that. So.
This is Tremaine joining.
Oh, hi, Tremaine. You're here.
Hi. Yeah, sorry for the lateness.
That's okay. You can push *6 to mute yourself, or you don't have to, but if you're kind of in a noisy area. And then I have Dr. Yorick on the line, and we're just kind of talking back and forth. And actually, since you kind of opened up the opportunity, does anybody have questions for Dr. Yorick on anything that he's said or anything that I've said so far? Just push *6 to unmute yourself so we can hear you if you're muted. Anyone? I'll give it a couple more seconds. All right. So what I would say next then, Dr. Yorick, is it sounds like you even have a hard time. So I think all of us myofunctional therapists kind of think, we're out there talking to dentists and they don't get it, but we're not doctors, so maybe that's why. But you're a doctor, and it sounds like even other doctors that you talk to are kind of, I don't want to say clueless, that sounds mean, but are kind of not really on board with what you're looking at. What do you have to say about that?
Well, there are some orthodontists. I don't know what percentage of the population in Seattle Tacoma areas, but they don't think in functional terms. They're interested in producing a set of study models at the end of the treatment that fit together a certain way, and that's pretty much the scope of their treatment. And in cases where there are no airway issues, that's probably just fine. But in cases where there are airway issues or growth and development issues, habit issues, then that mode of treatment is not going to be successful, nor is it going to be appropriate for that patient. So that's, you can ask leading questions. You can mention the thing about the open bite tongue thrust connection and tongue spines connection, and then kind of keep opening the door for them. Or ask them, another leading question like, well, in your cases that relapse, what, especially if the bite opens, what do you think caused that? Make them answer the question, make them think, because that then you have an opportunity to get them thinking outside the box a little bit. The MDs is a different situation because there's insurance issues and there's these network issues and referral patterns that may exist within networks where there may be other factors involved in whether the patient actually is approved or recommended surgery. Let's say adenoids out or tonsils out by an ENT that gets outside of the box of human physiology and gets into politics a little bit. So that's a little bit harder thing, and that's one of my challenges is to spread the word in the medical community about airway and the importance of early removal of the adenoids and tonsils and retraining and repositioning of the tongue postures. And, we try to get their attention. We take them out to lunch. We try to present, if they gather in like a morning meeting, sometimes I'll go and do a little breakfast and learn with them when they, like at the sleep places, the sleep centers, they sometimes have a morning huddle once a month and they kind of go over all their internal business. So I try to show up and, gather 5 minutes at a time and get them thinking in terms of orthodontic development of the arches and or orthodontic appliances for sleep apnea treatment.
Yeah, I think I don't know how many people are kind of surprised and kind of in awe and stuff that it's not just us as myofunctional therapists that have to go out there and try to spread the word and talk about the airway and the tongue and the mouth resting posture. Dr. York is an orthodontist and he has tons of experience, and he still has to go out and do office lunch and learns and go talk to these other doctors who really don't understand what he's doing and why he's looking at these things. So I think that's pretty cool to learn personally as I'm listening right now. And I know, Dr. York, you were also telling me yesterday about your experience going into a sleep clinic, and I think that would be really cool to share with everybody what you've done in sleep clinics.
Well, there's I guess the good news for the sleep clinics is that there's starting to be an awareness on the medical side of the coin of the value of oral appliances. I'm not sure the exact wording, but I think the big sleep medicine meeting that was in Seattle this summer, both the dental and the medical people, I think, came up with a position paper at that meeting saying that oral appliances for mild and moderate sleep apnea should be recommended parallel with or with CPAP. And so I've seen a little bit of an opening there, and I've got more referrals lately, I think, because they made a decision as a body to embrace oral appliances. When I first started doing this 7 years ago, I actually would visit the sleep labs and try to talk to the techs, the guys that actually consult with the patients, because the medical doctors there's kind of a line in the sand. There were the neurologists that do sleep medicine, and there's the pulmonologists, and the pulmonologists don't seem remotely interested. The ones I met anyway are interested in oral appliances, and the neurologists are very interested in them. So you try to find which side of the fence they are, and then you take the doctor out to lunch and you talk to them about what we can do and how we do it, and then try to get in front of the staff at the sleep center, especially the technicians that actually deliver the CPAP, because they're going to get people that are going to come back and bring the CPAP back to them and go, can't do this, and then the technician go, well, there's a plan B, so.
No, that's really good. I know that a lot of the sleep doctors don't even really understand how the oral appliances work. So I think you were explaining to me before that you've actually gone into the sleep clinics for your own appointment and ended up explaining things to many of the patients there about oral appliances. Do I have that right?
Yeah, I've done that, and first of all, they're usually somewhat relieved because now they can offer these CPAP dropouts an alternative. And where you guys get involved is, the more forward and upward we can get that tongue, the more we open the airway. So now as I work with my apnea patients and look at appliance design, the apnea appliance designs, I'm looking for ways to encourage the tongue to come upward and forward. And then the more severe the case of apnea and the larger the tongue and the more constricted the airways, the more I want to design my appliance to try to get the tongue forward and up. And where you guys come in is that, your exercises do the same thing. So in the adults it's going to be harder, of course, but, we can get these kids in earlier and teach them, get their palate nice and wide and get their airway opened up. If they need to have their tonsils out, adenoids out, let's do that. And then let's get the tongue up and forward. And that way you prevent another generation from growing up with sleep apnea. So there's where I think the value of your profession is, and that's really my biggest challenge right now in my practice is to get children diagnosed and get them treated properly so that we don't just keep perpetuating this sort of epidemic of sleep apnea we have in our country. It's kind of sad, but so I've got it working on, and particularly in case you guys are interested in the positioning of the mandible for apnea. For a while we just pulled our jaw straight forward, but now we're looking at, especially with the cone beams, now we can see what we're doing with the position and take a new film and look at their airway in 3 dimensions with the cone beam now. But I'm looking at opening the vertical up more, like making the mandible rotate vertically and also come forward, and then that pulls the airway open and it also pulls the tongue forward. And I'm trying to keep the appliance so that there's very little in the front, like in the incisor area, very little acrylic, so the tongue has like an opening that's come forward through into that opening, because that also opens up the airway. So you guys are doing the same thing. You're basically encouraging kids with low tongue posture to have an upward and forward tongue posture. So it's really the same thing. We're doing the same thing.
Yeah, that's pretty cool.
So, yeah, it is. And so, of course, we talked about earlier, getting the word out and getting people networking together and working with this and recognize the problem is where I see the real problem and the real opportunity. So.
Exactly. And it sounds like you must have a network of these doctors and sleep specialists and things that you know in your area where you practice. Is that pretty solid? Is that always like kind of, you're always trying to make new connections and stuff, or?
Well, I have a pretty good network to work with here. I have a couple of sleep physicians that I work with a lot, and there are a few more out there that have not paid much attention to oral appliances, and so as I was talking to you yesterday, I realized I need to don't give up. Probably need to go back out there, and maybe they have a new staff back there now that's more open. A lot of times in the sleep clinics or in sleep practice, a lot of times the physician doesn't really see the patient. They have techs that conduct the sleep study, and they have techs that fit the CPAP, and they have techs that monitor the CPAP. So maybe they got a new tech. Maybe this tech knows oral appliances. So I guess I'm going to go back and revisit places like St. Clair, and maybe even go back to TG and their sleep center and revisit those techs and remind them that, hey, I specialize in jaw appliances. That's what I do, so I can really help your apnea patients. So we're all faced with the same issues on that. But I just encourage everybody, don't give up. Just keep at it. It's work that needs to be done.
It does, yeah. And it is hard. I kind of find that I'll get discouraged too, and then I'll stop talking to doctors for a while. I'll stop reaching out after you get told no so many times, or you get kind of like, oh, that's nice so many times, and you tend to kind of just keep doing your own thing and working with people that get what you're doing. But it is important to just keep reaching out, because you never know. You might reach out for the third time or try someone new, and all of a sudden they say, oh yeah, I was just at a conference and I need someone like you. So hopefully people are kind of staying educated and looking at the research. There is a ton of research coming out about sleep apnea connected to all types of things that we never would have expected. Even mental disorders like depression and anxiety. I just found 3 articles after this conference connecting sleep apnea and an obstructed upper airway to anxiety and depression, which is amazing. So it's all out there, but another thing that I heard was that it takes about 20 years from something that's published as research to become mainstream and have it every doctor knows about it and everybody practices that way. And that, I think, oh my gosh, that's a long time. What changes have you noticed since you started this stuff so many years ago and now you're still doing it? Do you think that it's gaining momentum? Do you think people are starting to look outside the box, or I don't know, what's your opinion?
I think that they are. I mean, as an example, there was a big course offered, really nice course offered. I think it was called The Airway and Dentistry, and it was a big 3-weekend course given over like a 6-month period of time. We went actually 3 separate weekends, and there were really good speakers from medical and dental, and it was offered by a pretty big outfit. And I think a lot of dentists around the country were sent this really nice brochure about it, and as I looked over the curriculum, I was like, wow, this word's getting out.
Yeah,
and like I said, it's nice. And earlier I said, I mentioned earlier that the medical community now is recognizing oral appliances more and more now. It's totally different than when I started this 7 years ago. So I see that as encouraging. I think the Northwest is a fairly progressive area, so I think we're going to have more of an early adoption of these techniques. So we need to hang in there. And just unrelated to that angle, but we need to do what's best for our patients.
Yes.
And we need to get better at what we do. So we know this is the best thing for our patients. If you guys stick together and do your study clubs and stuff, you get better and better at what you do. And so the patient gets the very best possible care, regardless of what the dental culture is saying out there, whether it's popular or not. It doesn't matter. What matters is that you're doing the very best thing for the patient, and you're getting better at what you're doing. But as you kind of market yourself, you're kind of forced to stay up on all the new stuff and learn, and that's how we get better.
I think that's really good advice. I think that probably makes all of us a little bit more encouraged out there. I think always doing what's best for our patients is really the point of it all, right?
Exactly.
So, even if it's hard, it does make it a little bit harder when you do care, right?
But then you're excited about Monday morning coming around because you learn some new stuff and you want to go back to your office and you want to use it to benefit your patients. So it makes your job very exciting and rewarding. I wouldn't think it would be so great to go back to Monday morning and just do the same thing you did last Monday.
I know.
Know the same knowledge if you know the same body of knowledge and it doesn't change over the years. That's kind of a boring way to live your life. So I'd rather be out there kind of on the edge than saying, well, I'm old enough to be looking back. I'm looking at the end of my career now. I would hate to be looking back at my career going, I could have learned more. I could have done more. I should have been more involved with blank. I don't want to.
Good advice. Yeah.
Any of us to do that. You want to leave it all in the field.
Exactly.
That's what you want to do.
Yeah, that's really good. Let's just pause again. Does anybody have questions for Dr. Yorick? He's got so much knowledge and advice, and it'd be great if anybody has anything they want to ask him.
Yeah, this is Debbie.
Oh, go ahead.
Let's hear Debbie.
This is Debbie, and I do have a question. You made mention that you said that airway breathing through the nose causes the adenoids to shrink, and then later on you said that if they have large adenoids or tonsils, that's one of the first things that you want to remove. So I just wanted to find out when you decide, which patients would you decide to remove the adenoids and tonsils, and which ones would you decide to let them try to breathe through their nose?
That's a great question. I was just at the sleep meeting in Seattle, and there was a wonderful orthodontist there that practices in Oregon, and he was a wonderful airway guy, and he was talking about his one of his children, and his children had mild to moderately enlarged adenoids, didn't have a lot of the really horrible things associated with open mouth posture. He was a mild case. So adenoids of a mild to moderate size. He had some symptoms of breathing disorder, but not all of them. So he forced the child, his own son, to breathe through his nose, forced it out. He did a little gentle palatal expansion using a removable appliance. He documented it, and over a 2-year period of time, the son, the adenoid shrunk, and the son no longer had an airway issue. So I would say mild cases of adenoid blockage, mild cases of sleep disorder, or mild cases of airway obstruction. Yes, if they're moderate to severe, they're probably better served by getting the adenoids out and starting some pretty aggressive I would say two other things. I would recommend also someone look at the size of the palate and see whether it needs to be enlarged. And then the third Holy Trinity, the third part of the Trinity is you got to get the tongue in the right spot. That's where you guys come in to get the tongue up and into that palate. And then that kid is pretty much, I wouldn't say cured, but he has a much better future. It takes all three.
Awesome.
Okay.
Great. That's a great question.
Thank you. And I think it was that Tremaine that said something else?
No, my name is Sarah. I actually have a question. I know that you said that you are 100% ortho practice. Now, I'm not an oral facial myofunctional therapist, but this, as a dental hygienist, has just been brought up to me to an opportunity to expand my career. My curiosity is this. I know that you talk about early intervention and doing your retreatments and treatments in tandem with myofunctional therapy, but my question is, how often or do you refer out to a myofunctional therapist, or do you do myofunctional therapy yourself?
We've done both. We do most of it in-house, and that's simply an issue of maybe it's us, but we have a hard time getting our patients to follow through and make their appointments with the oral myofunctional person. I feel bad about it, but the reality is that in a busy practice, we found that we have probably a better success rate if we have their attention. We've captured their attention while they're in our office, so we try to do it our best. In the ideal world, actually, we would have someone that we work very nearby, or someone working in our office that could see a bunch of these patients. But we've had a problem, and you guys have the same issue. It's getting these kids to actually, and their parents, to devote the time and energy to it. It's a failure for which I feel very poorly, because I feel like we should be doing a better job with that. But that's the reality, is that it's just easier and more efficient for us to try to do our own version of it. But I feel really you guys should be doing it more than we are.
Recommendation then to us new therapists who are trying to start a career, what would you then recommend to us? Maybe come in, meet you, shadow you, do a one-on-one with your office, maybe the patient themselves in your chair to develop a relationship? Or would you then encourage us to find an orthodontist just to refer to us?
I can speak to that a little bit, if you don't mind, Dr. York, because that's kind of what I've done with Dr. York before. The problem with us is that my office is way up north in Seattle, which, if you guys are familiar with the area, it's about an hour drive, maybe more, in traffic to get down to his office. So, to get patients to drive up to Seattle to see me is pretty hard. I think it was 3 years ago, wasn't it, Dr. York, that I was going to your office?
Yeah.
I was going into his office one day a week for a little while and seeing patients, but that kind of faded out for me as I got busier, in my West Seattle location, and so I actually feel a little bit bad about that too. But with the invention of, Skype, and sometimes people do want to work online, there are options for seeing patients that way. It's not as ideal as, the in-person thing, but I know that if Nicole is on the line, she is she's down somewhere, I think Puyallup, Tacoma area, and she'd actually heard of Dr. York's name, so he might have an option.
I'm here.
Down. Oh, you are, yeah.
I'm Puyallup, Tacoma.
Yeah, so Nicole's in that area, so who knows, Dr. York, it might be a chance to kind of, reinvigorate some of those patients by sending them to Nicole once she gets up and running.
Yes, I think I can do that. We get lazy and we get in patterns, and we can get unlazy, and we can develop better patterns of referrals, especially if someone's close. And what I would need from that person would be
when they're far away, right? When I'm up in Seattle, nobody wants to drive there, especially. Yeah.
So I could get together a group of patients, them to come to the office at a certain time, and then Nicole could come and meet them and meet the moms and talk about her particular pattern. Of course, her particular program. I can also tell the mom, the benefits of having a person do it, because I think especially the women are better with motivating the children. You can do reward programs and things that we simply just don't have time to do, and you can do all the follow through and stuff that makes it work. And
Dr. York does have a pretty good. You do have a pretty good program. I mean, he talks about putting your tongue on the spot. He talks about nasal breathing. I think the girls teach a few basic exercises about lip feel and stuff like that. So he's doing more than most for sure. And I'm just glad that his patients do have that. And then like I said, now that Nicole's in that area, maybe she can get more involved too. So that'd be pretty cool.
That's super exciting. All over that.
Yeah, if you think you can, for people in an area that if you're thinking about, beginning your own practice, I would probably just, meet with the orthodontist in the area and get their feel for awareness about airway and tongue issues. And if you've got a couple of guys in the area that are thinking in terms of myofunctional therapy and want someone to work with, then you could you can present yourself as someone who's willing to offer that service. And a lot of guys, especially guys that maybe don't do as much as we do, they would much more refer it out.
A lot would rather refer out because, as you know,
I think most would.
It's an extra thing that you have to talk to patients about and that your staff has to spend time doing. And so I think most orthodontists would rather refer out. But you're pretty unique. For so long, I think you didn't have anyone to refer to. And then I met you like 3 years ago or 4 years ago, and I was impressed that you were even doing anything. That's more than most doctors do. So it's good. Any other questions for Dr. Yorick? I know somebody was asking, or somebody was.
This is Erica. Hello. I actually talked to a speech pathologist who does myofunctional therapy, and she was actually thinking about opening up like a clinic with an orthodontist and like having several patients that want her teaching them the therapies or exercises. And I'm actually focusing myself towards working for an orthodontist. Do you recommend the clinic part of it, or would you say working one-on-one is a better, more, I guess, better way to go, better approach?
I think anything you can do to get you both under the same roof is a really good idea.
Mm-hmm.
Okay.
You can support each other.
Okay.
And if you become woven into the fabric of that office, then you're going to be much more successful.
Okay, great.
That's my recommendation.
Okay.
Plus, when you're kind of there in front of each other all the time, it kind of reminds you of the whole referral process too. When you're there all the time, right?
Yeah, I think that would be a wonderful thing. It might not be a full-time thing right off the bat, but you establish a relationship. You give it a day or two a week or whatever you decide to do, and you grow it from there. And if it works good, then he'll tell his buddies, and they'll his other orthodontic buddies, and they'll send their patients to you. Maybe under a different, it might be a Skype situation, or maybe it might have another location. I don't think an orthodontist is going to be worried that he's going to lose a patient to the other orthodontist. I think you might gather up a network of a couple or two or three orthodontists, and maybe there might be a pediatric dentist. I think the pediatric dental community is probably should be the main source of our patients, really, because they're seeing those young children with these early problems.
I agree.
And that would be, I would think a pediatric dentist would be. I would love to have one on my team, I tell you.
Yeah, that's a really good point. I think the pediatric dentist could be like the best key referral sources because they catch the kids with the thumb sucking habits, the large tonsils and really early airway issues. So a lot of it's even more in their hands than the orthodontist. They just have to kind of know what to look for, and
that's exactly right. we get so many kids that 13, 14 rather than seeing this for the first time, and someone should be talking to them about airway when they're 5 or 6. That's when they really need to be diagnosed properly and treated properly. So that's one of my challenges I mentioned earlier is trying to influence the pediatric community, both dental and medical, to diagnose, get these kids diagnosed properly and get them shunted to an area of treatment, whether it be orthodontically, palatal expansion, myofunctional with the tongue, probably both actually, and then also having the courage to talk with the parents about adenoids and tonsils out. No one wants to do that, but someone has to be their advocate if the medical community is flipping up, and the medical community, as you know, is getting more and more fragmented. It's harder and harder to get like a normal doctor now that takes an interest in you. So many of these kids, unless they get tonsillitis, for example, no one's really even looking at their airway. And they certainly aren't radiographing it like we are, talking about tonsils and showing them their airway. And if you're anywhere near a facility that offers three-dimensional head film, they can even colorize the airway for you now, so you can show mom in living color her child's would be the airway. We have to be the advocates for that, and then we have to bring the pediatric community along with us to be advocates as well. And then I think we'll start changing the health culture around sleep apnea and airway issues, in this country. That's not someday, one day.
Yeah, that's what we need to do. Does anybody else have questions for Dr. Yorick?
Yeah, I do. This is Roxy.
Hi.
So I missed part of the beginning part. So if you already answered this, I apologize. But my question was, if you have a dentist or a dentist who is interested in getting more into the airway aspect, I don't know, where was your first step to go to start training for these things? Was there a particular, class that you took or one that you would recommend over the next one? Because I'm speaking to an orthodontist now who wants to get more into the airway stuff, and also my dentist, and they're asking me where they should go, and I'm like, I don't know.
I think I know I can help you with that because I've been down that path. I think for the dentist, he's going to be treating sleep apnea patients, and so the American Academy of Dental Sleep Medicine gives an introductory course I usually offer to different places around the country. It's excellent. I think it's 2 days, and that he'll come back from that course with everything he needs to do to start practicing. And then the orthodontic one, I would say same course, but then I would add the 4-day course that the American Academy of Oral Myofunctional Therapy gives. That's a wonderful course for an orthodontist. That's a life changer. So those 2 courses, maybe the dentist may or may not need to take the myofunction one, but the orthodontist does need to take that one, and they'll thank you because they'll change their life.
Okay, thank you.
You bet.
Yeah, that's a good question. So anybody else who has doctors that they work with who are interested in this but don't know where to get started, there you go. That's a perfect place. Anything else? All right. It sounds like that's it. So unless you want to say anything else or kind of say some, words to conclude, Dr. Yorick, I'll let you go. I don't want to take too much of your time. And then if anybody else wants to stay on after, or if you want to stay on and keep listening and about what I have to say, I was just going to say a couple words about the AAMS meeting that I went to. I know some people wanted to hear about that. So anything else from you, Dr. Yorick, that you'd like to add?
Just don't give up. We're all trying to we dedicate our lives to customer to patient care, and the object for all of this is just to offer the best care and every day for us to get better at what we do, not only just treatment wise but diagnostically. So that's why these opportunities to learn from each other are so important, and to spread the knowledge that we have and incorporate more people into our network that's the joy and the challenge of doing all this. And don't be discouraged. You're doing the right thing. Just keep at it. And if there's anything I can do to help you guys, just let me know, because I'll be happy to do that.
Yay. Okay, that's so nice of you. Thank you so much, Dr. Yorick. I think everybody here learned from what you had to say, and I think it's so good for us to hear these doctors who get what we're doing and who are also kind of, I don't want to say fighting the same battle, but, we all understand the struggles that come with being in a field and talking about things that aren't necessarily, the mainstream way of looking at stuff. So whether that's orthodontics or the airway or the tongue, I think it's just really good for all of us to hear that you have a lot of our similar experiences. So thank you so much for sharing.
You're welcome. My pleasure.
Yeah.
Thank you.
All right.
Okay.
Thank you.
Thank you.
Bye. Okay.